We're going to talk about professionalism. Webster's Dictionary defines professionalism as the conduct, aims, or qualities that characterize or mark a profession or a professional person. So this diagram is going to show, for example, attributes of a physician. And we're going to make some correlations to EMS from this. So a physician has two large roles. One is as a healer and one is as a professional. And so what we find is that many of the attributes of a healer are also the same as what we would see in EMS. So we see things such as caring and compassion, insight, openness, respect for the healing function, respect for patient dignity and autonomy, competence, commitment, confidentiality, trustworthiness, integrity, honesty, ethics, and responsibility to a profession. And then we see attributes of a professional are much of the ones from the healer, as well as autonomy, self-regulation by associations and institutions, responsibility to society, and teamwork. And so we see many of these, and where these two intersect is many times where we see what the major attributes of a profession are. One of the attributes that kind of falls outside of this intersection is autonomy. At the present time, EMS is not autonomous, meaning that we are not self-regulating. Where physicians groups have regulate their own industry, we are regulated by state government. And so that is something that is evolving. In Canada, one of their provinces within the last couple of years actually became self-regulating. So there's a lot that goes into that with education, for example. But we can take a lot from these various attributes and put them into our profession, and they actually do apply to our profession. So I mentioned education just briefly earlier. Education is somewhat of the elephant in the room. And so we're going to talk about that just briefly, and we'll have more of a discussion in class. Here's some things to think about, and you might jot some notes down and bring your answers to class. What does formal education provide? So you might think about that. And does education make you a professional? Something to think about. And another one that I might add on to this with education is, does formal education always make you a better EMT, advanced EMT, or paramedic? So some things you might think about. So one of the attributes of a profession is having a cohesive code of ethics. Unfortunately, the way EMS is regulated state by state, there is not a mandated code of ethics that's national. Some states will have codes of ethics. In fact, I mentioned the new rules that are in the works in Indiana. There is a code of ethics in that. So once that is passed, then those ethics and breaching of those ethics will be regulated by the Department of Homeland Security. Currently, the National Association of EMTs has a code of ethics that they've had for a very long time, and it's recently been updated. But here's some things to think about, and we'll talk about the NAEMT code of ethics in class. So what makes an EMS professional? Is it professional image and behavior? Does it matter if we're on or off duty? An EMS professional must instill confidence and establish and maintain credibility. One of the things that we have to do is when someone calls us for help, we have a very short period of time to instill confidence in that patient that we are competent and professional. Many people are, if you, for example, look sloppy and you're rude to the patient, that's not going to instill confidence, and that patient's not going to want you to treat them. One thing to remember, you are part of the healthcare system. You must treat others with respect. That means patients, your coworkers, and those other healthcare professionals as well. One of the key things about being a professional is that you are a patient advocate, and that means a patient advocate in every way. So not only for their health care, but also where health care relates to maybe some financial issues, and we'll talk about that. It'll be much later in the course, but we'll talk about that. For example, with air medical services and the cost of air medical services. But this also plays a major role with taking people to hospitals, for example, that are out of their insurance network. Sometimes that's what they need, but the patient has a right to make an educated decision on whether or not they want to do that, where they want to go, the health care that they want to receive. Other attributes of EMS professionals is self-reflection and self-assessment. It's important that we be able to look at our performance and look at ourselves and say, am I the very best EMS professional that I can be? What areas do I need to improve on? And then search out those things to improve ourselves, both personally and professionally. And it's not always something that may be paid for by your EMS agency. Again, this is self-reflection, self-assessment. It's important to be empathetic. You want to try your best to understand the situation that our patients are in. Sometimes it's very difficult. Sometimes our patients have created their problem through their actions, but we still need to try to understand where they're coming from. We need to be able to communicate well in verbal and written form. Very important that we have verbal skills to be able to communicate with patients, be able to communicate with other professionals and physicians, and written communication with documentation of what the care that we provide. It's important that we be self-motivated. There has to be an underlying reason why you're doing EMS. Excuse me. And so it is important to be self-motivated. And if you're not self-motivated, then maybe this isn't the profession for you. Promote your profession in your community. Many EMS agencies do this through teaching CPR and first aid classes. Fire agencies do this through fire prevention, teaching people how to use fire extinguishers, putting smoke detectors, for example, into homes, replacement of batteries for carbon monoxide monitors, for smoke detectors, etc. So it's important that we provide our community with our knowledge and that they benefit from that. And it's also important that we're clinically excellent. We each have a scope of practice, each of the various levels of EMS providers, but within our scope of practice, it is important that we attempt to do the best clinical care that we can possibly do. And administration, and many of us, many people in EMS don't like to think about administration, but there is an element of administration in everything we do. For example, we may not want to think that the billing aspect is part of our job, but that provides revenue that goes into providing your agency with new equipment, better pay, for example, and better benefits. So every aspect of the administrative area affects what we do. So the next little segment is going to talk about patient safety. Patient safety has been a hot button in healthcare since the late 1990s. This book was written, this report from the Institute of Medicine, it's called "To Err is Human," and it was written in 1999. It was a landmark report on the health of healthcare. And what we found from this report was that in 1999, there were a lot of medical errors going on. And what we found out since is that these numbers are extremely conservative. The errors that are going on in healthcare today are much greater than what this report found in 1999. So here's what we learned. We learned that preventable adverse events are the leading cause of death in the United States. So unfortunately, the Centers for Disease Control does not consider preventable adverse events as a cause of death. But if it did, it would be above cardiovascular problems, cancer, and all other healthcare problems. In 1999, this report found that somewhere between 44,000 to 98,000 Americans die in hospitals each year as a result of medical errors. Now notice this said in hospitals, didn't say anything about EMS. And this range of 44,000 to 98,000 is a huge range because it was very difficult to try to figure out what kind of medical errors were going on, because medical errors greatly go unreported. So this was found to be a gross underestimate. The deaths attributable to preventable adverse events is greater than motor vehicle accidents, breast cancer, or AIDS. The total national cost for preventable adverse events in 1999 in this report was $17 billion to $29 billion. To put that in perspective, in today's dollars, that's $25 to $42 billion that these preventable adverse events cost the healthcare system. More Americans die every year of medication errors than are killed in workplace injuries. And the hospitalization costs of medication errors is about $2 billion annually. And that was in 1999 dollars. So exactly what is an error? The failure of a planned action to be completed as intended, example, error of execution, or the use of a wrong plan to achieve an aim, for example, an error in planning, is what this report called an error. An adverse event is an injury caused by medical management rather than the underlying condition of the patient. An adverse event attributable to error is a preventable adverse event. So in healthcare today, any adverse event is considered a preventable error, because there is something, whether it may not have been the intent of the medical provider to make that error. It may have been a system error, but somewhere along the path of treating that patient, there was a chain of events that occurred that could have been prevented. So let's look at some types of errors. We have diagnostic errors, which are errors or delay in diagnosis, failure to employ indicated tests, use of outmoded tests or therapy, and failure to act on results of monitoring or testing. We have treatment errors, an error in performance of an operation, a procedure, or a test, an error in administering the treatment, an error in the dose or method of using a drug, avoidable delay in treatment or in responding to an abnormal test, inappropriate or not indicated care. So as we look down through these diagnostic and treatment errors, think about things in EMS where these might be an issue. Many of us have probably encountered some of these with within the healthcare system with ourselves, or maybe even a family member. Preventative errors: failure to provide prophylactic treatment, inadequate monitoring or follow-up of treatment. Other errors: failure of communication, huge problem. Communication has been found to be a huge issue within healthcare. This is communication not just between physician and nurse or physician and paramedic, but communications between pharmacies, between nurses changing shifts, between other people giving a variety of types of treatment and therapy. There's equipment failure, and there's other system failures. So where in the process, looking at medication errors, where are these occurring at in the process? So knowledge of drug therapy accounts for about 30% of medication errors. About 29% of medication errors are caused by knowledge of factors that affect drug therapy. Calculations, decimal points, unit or rate expression factors account for a little over 17% of these errors. And again, this is one of those places where in EMS we suspect that we have a huge number of errors. Nomenclature can be a problem. For example, incorrect drug name, dosage form, abbreviations. A little over 13% is attributed to this. A lot of change has taken place since 1999 due to this report with trying to simplify medication dosages, trying to put medications in unit dose containers, trying to get away from some abbreviations and what's referred to as look-alike or sound-alike medications. The medication use process creates some errors as well. So for example, prescribing, the need for and selecting the correct drug. Again, in EMS, we don't technically prescribe drugs, but we do decide as paramedics and also EMTs and advanced EMTs, we do decide when is the right time to give a medication. Are we selecting the right drug? And are we using the proper therapeutic regimen? Are we redosing at the correct times? And designating the desired therapeutic response. So are we looking at and documenting a response to our therapy that we provide? Dispensing, again, technically we don't dispense medications, but we really do. Dispensing is a term that is used with pharmacists when they're actually giving out medications for others to use. But it's looking at reviewing the order or reviewing what the appropriate dosages are that we need to be giving our patients. Processing the order, compounding and preparing the drug. We don't often mix medications anymore. When I got into EMS, it wasn't uncommon for paramedics to mix actual medications, and within hospitals as well, nurses were mixing medications. Most of that is now done by pharmacy. By your pharmacy and the pharmacists to reduce errors. Dispensing the drug in a timely manner. So are we giving our medications to our patients when they are supposed to be given? So administering the drug. When we talk about pharmacology in our course, we'll talk about some of these things. The right medication to the right patient. Administering it at the right time. Informing the patient about the medication. And including the patient in the administration. So finding out, again, doing a good and thorough history, does the patient have any medications, or allergies to medications? So, it's important that we tell the patient, if they're able to understand, what we're going to do, what we're going to give them. Looking at monitoring and documenting the patient's response. Identifying and reporting adverse drug events, reevaluating drug selection, regimen, frequency, and duration. Medication use process. So there are also errors that are caused by systems and management control. Collaboration and communication among caregivers. It's very important that we communicate and that we give good, thorough reports to those that we're handing patients off to, or those that we are relaying orders to. Reviewing and managing patients' complete therapeutic drug regimen. Oftentimes not a function in EMS, but it is an issue within the broader healthcare system. So why do errors happen in the first place? So our first reaction is to place blame. Most medication errors are not caused because a provider has a malintent. Most of them are simply mistakes. Oftentimes they're systems problems. So we need to start looking at taking a lesson from the airline industry. They go through a very exhaustive investigation every time there's an aviation crash. And, there's often speculation as to, was it pilot error or mechanical error or whatever. But they go through a very exhaustive process with looking at the systems in general. And aviation has been made much safer because of that. Healthcare isn't that progressed yet with doing that. So we need to look at preventing errors and improving safety for patients that require a systems approach. The problem is not necessarily bad people. The problem is that systems need to be made safer. And since 1999, many of these systems have been made safer. And also, especially going back to the 1980s with SHARPS and the HIV and the AIDS problem in the early 1980s, created safer sharps, safer needles, and needleless systems and that sort of thing.